here. I'd like to thank Bruno and his wonderful team at MedInvest for having us over. My name is, as you heard, Glen Calderhead. I'm the Vice President of Medical Scientific Affairs at Lutronic. I'm also an Executive Vice President of the company. And my main aim in the company is to make sure that all our science is correct, because without science there is no medicine. As for experience, I've been in the laser field since 1976, probably before most of you were born. I wish it was before I was born. So, I've specialized in low-level laser or low-level light therapy since 1982, so that is also side by side with laser surgery. And today you've heard some wonderful stuff from lasers and from energy-based devices, but what I'm going to talk about now is how to achieve a clinical effect but without heat and without damage. In other words, I'm going to invite you to join the wound healing revolution. So the first question is, what is light emitting diode low level light therapy? Well, you can find it under the heading of phototherapy, and the official term in the medical system dictionary is photobiomodulation. But what actually is it? Well, light, as you know, travels in photons, little packets of energy without mass. And when these photons are absorbed in cells, they give up their energy to the cell. And the cell takes this energy and incorporates it in its own energy pool. And this photoactivates the cell. The cell has been activated by light. And that enhances the level of the cellular energy pool. And three things can happen to photoactivated cells. If they're damaged or compromised, they will be repaired by themselves or with a little help from their friends. Functional cells, such as, for example, fibroblasts, will do their job better and faster. And if there are not enough cells, then proliferation will occur, or more cells will be recruited in to do the job. So with 1, 2, or 3 of all these things happening together, we can achieve the viable clinical effect I talked about, but without heat and without damage. Now you're probably sitting there thinking, yes, that's right. So just in case you were a little skeptical, I suggest you go to PubMed and search under the term LLLT. When I search, this one says 7,795 hits. That was a couple of weeks ago. Today it was 7,980 hits. And remember that these are all peer-reviewed papers. Only peer-reviewed journals are indexed in PubMed. So you can see there is an enormous body of evidence that LLLT exists and works. So let's take a cell and let's give it a damage threshold and a survival threshold. And then let's pump in light energy in increasing levels, and this of course in turn stimulates increasing levels of activity within the cell. If we can keep that level of activity below that damage threshold, we have achieved athermal photobiomodulation, LLLT. If we keep on pushing in energy, then we'll start to heat up the cells and we'll damage them, although we won't destroy them. But if we continue to pump in energy in increasing levels, then we will either blow the cell to pieces, that's the ablation, or we will cook the cell, coagulation. both of which you've heard about today. But what we're interested in is LLLT, low level light therapy, where the word level deals with the level of the tissue reaction and nothing to do with the level of the power. Because LLLT contains the word light, it must therefore follow the first law of photobiology. So does laser. If there is no absorption, there is no reaction. So if I asked you what is the prime determinant of both absorption and depth of penetration, you'd probably think power, but in fact it's not. It's wavelength, because wavelength determines target selection, which is also known as the chromophore, and the depth of penetration. So it's critical to understand penetration and wavelength. So here we have a blank photospectrogram. Right? A photospectrogram measures the optical density of the target substance. And in this case, it's by hand. The projector is placed above the hand, the receptor is placed below the hand. And light from 400 to 1100 nanometers, so-called white light, is beamed into the hand, received here, and then this is then compared with the light that has gone in for each wavelength. And that allows us to show the depth of penetration of each wavelength through living human tissue. You can see that blue 415 and yellow 590 have very high optical densities. That means penetration is very poor. We move only 43 nanometers, 43 billionths of a meter, and we get red at 633, which is 4 orders of magnitude better penetrating than 590. And that means 10,000 times better penetrating. So if you want to get light deep into the tissue, you've got to go to red or to near infrared at 830, the deepest penetrating wavelength. Why do we have differential penetration? Well, you've heard today about targeting specific chromophores, blood and melanin. 415 nanometers targets both blood and melanin. 590 nanometers yellow targets both blood and melanin. Therefore, it doesn't penetrate into tissue. So if you want to get deep, you've got to go from about 620 to about 1,100. Alrighty. So the next question is, why should we use light-emitting diodes when there are other forms of light? Well, if you'd been asking me this question 20 years ago, I would have been rolling on the floor laughing, because LEDs were a joke, clinically speaking. They were cheap, they were cheerful, they were incredibly bright, but they delivered a wave band, not a wavelength, and they had very low and unstable output powers, and they were highly divergent. So you could get a red LED, but it covered a wide waveband. And when we want to target specific things in our body, we need specific wavelengths. So this changed in 1998 with my friend Professor Harry Whelan. Harry and his mates in the NASA Space Medicine Laboratory developed the NASA LED. This was a system with 5 orders of magnitude more power. That's 100,000 times more powerful. Moreover, it had stable and consistent output powers, and it was, most importantly, quasi-monochromatic. Quasi meaning almost, and monochromatic meaning one color, like a laser. So that meant that finally we could have a specific red wavelength, for example, 633 nanometers, or any wavelength we wanted, plus or minus a few nanometers, because LED energy is non-coherent, unlike laser, which is coherent. So monochromaticity versus quasi-monochromaticity. LEDs have inherent advantages. They are very efficient. They take very little light, very little electricity, and produce tons of light. This keeps running costs down. They have no filaments, they have no flash lamps, so they don't use energy to create that light except the electricity going through them, because they're solid state. They can be mounted in large flat planar arrays, so that as therapists you just set up the system over your target skin and you can go away. Hands-free treatment, very therapist non-intensive. They are quasi-monochromatic, meaning that more than 95% of the photons in good LEDs are at the rated wavelength, and the remainder are plus or minus a few nanometers, and that gives us laser-like target selectivity. And finally, they are inexpensive. Sip of my vodka. That keeps the costs down for you and for your patients. LED LLLT has advantages. It's not laser, so it can be given in many cities, in many states, in many countries. It can be given by a trained therapist. You don't have to be an MD. It's non-invasive and it's non-ionizing. It can be applied by a trained therapist. It's pain-free and side effect-free. In fact, it can treat pain and side effect, and it's well tolerated by patients of all ages, from infants to centenarians. So, let me introduce you to the aesthetic practitioner's little helper, LED low-level light therapy with Healite 2, my baby. I believe Healite 2 is a new concept in LED LLLT. It employs 3 tried and tested wavelengths. The main wavelength is 590, 830 assisted by 590. But this is very good for a variety of things, all aspects of wound healing, acute or chronic, traumatic or iatrogenic. Pain attenuation, acute or chronic, neurogenic, any kind of pain, bone regeneration, even slow union fractures, or it can be used to help implants be osseointegrated into the bone in which they have been implanted. It can help regrow crushed or transected nerves. It can be used in many, many aspects of sports medicine, skin rejuvenation, and even hair regrowth. The second wavelength that you could have is 633 nanometers, but really its main application is in photodynamic therapy, exogenous photodynamic therapy, or PDT, using aminolevulinic acid. This is for the treatment of such things as basal cell carcinoma, early stage squamous cell carcinoma, etc., etc. But this red 633 has also had some interesting efficacy in hair regrowth. And then the third wavelength is blue at 415 nanometers. It only has one application, and that is endogenous PDT, photodynamic therapy, for porphyrins that are already in our body, in Propionibacterium acnes, in the treatment of acne. But it has to be used in conjunction with 830. Because the 415 cannot deal with the inflammatory problem, it can't heal the wounds left by acne, and it can't deal with acne's autoimmunocompetent problem. So there are the 3 wavelengths, but the one that we deal with mostly is 830. What is the overall target? Well, it is the skin, as this gentleman is kindly displaying for you. Hope you all had a good lunch. As you know, the skin is the largest living organ in the human body. It protects us from nasty stuff coming from the outside, and it keeps all the good stuff good on the inside. Fair enough. But for us as therapists, it contains all of the target cells for LED therapy, and the dermal blood vessels are plentiful. In fact, at any given time, more than 20% of our blood is in our dermis. So, what does this mean? Well, it means that if you're giving somebody a photofacial, as you do that, the light is interacting with the skin cells, and it's creating all sorts of interesting photokines, chemokines, cytokines, and these all get picked up by the blood vessels and carried systemically through the body. So it's not just a local reaction, we also have a systemic reaction. So the primary target entity in the skin is skin cells. So let's remind ourselves a little bit about cellular biology. The cell is surrounded by its cytoplasm and contains surrounded by the cell membrane, which contains the cytoplasm, in the center of which we have the nucleus. Then we have some of the cellular organelles. We have lysosomes, the enzyme factories of the cell. We have ribosomes on the rough endoplasmic reticulum that manufacture messenger RNA that talks to the RNA in the nucleus. And then we have Golgi complex, which is like a little assembly plant. And these are all very interesting. But the most interesting one is mitochondrion. Because the mitochondrion is the energy factory of the cell, indeed the energy factory of our entire body. And they produce this wonderful substance, adenosine triphosphate, ATP. And a cell without ATP is like me without a good glass of Tripel in my hand. Unhappy and unfulfilled. So, of course, when we think of the main targets for phototherapy, then mitochondria must come very high on the list. But in fact, they are only the target for visible light, because only visible light can actually penetrate through the cell membrane and reach the organelles within the cell. There is a much larger target, and that is, of course, the cell membrane. So imagine, if you will, a little alleyway, and you're driving a little Mini, and you can whip your Mini into that alleyway without any problem. But if you're driving a Rolls, you cannot get your Rolls into that alleyway because it's too wide. So wavelength determines where the light can go. And with near infrared, the wavelength is just too wide to pass through the cell membrane, because the cell membrane is not solid. It's actually a little bunch of paired oils, if you like, so there is space between them. Visible light can go through that, but near infrared light cannot. So instead, it is absorbed in the membrane and excites the cell membrane, so we get excitation from the outside in to the out, which makes infrared light extremely effective. The main point was that visible light induces a photochemical response. Near infrared light induces a photophysical response. So although the end result is the same and you get a photoactivated cell, how you have achieved that result is different. So be careful when mixing visible and near infrared light simultaneously. Oh, there we go. So, what are the main wound healing cells? Here we go. We start with keratinocytes in the stratum basale, the mother keratinocytes, which make daughter keratinocytes, also ATP, calcium ions. Then we have fibroblasts, making collagen and elastin, and looking after the ground substance and maintaining the integrity of the ECM. Then we have for bone myoblasts and for muscle osteoblasts doing the same thing. Then we have the main inflammatory cells, mast cells, which are granular cells, macrophages, which are like our dustmen, keeping the ECM nice and clean, and neutrophils, which are like our policemen, our first line of defense against invading pathogens. Mast cells, macrophages, and neutrophils, when they are activated with 830 nanometers, release growth factors, very powerful growth factors. And these are important for fibroblasts in the second stage of wound healing. And when we look at the literature and the wavelengths of cells, the wavelengths that are known to excite these cells, you can see 830 does them all to a lesser or greater extent. But it will activate all wound healing cells. So the main process is, as you have guessed, wound healing. And you have to remember that when we talk about skin rejuvenation, just as Narabal was saying, what is skin rejuvenation? It is nice new collagen. It is nice new elastic fibers. It's plumped up proteoglycans, the ground substance. And what is that? That is wound healing. So skin rejuvenation is wound healing. So keep that in mind. And what about wound healing? Well, it involves different cells in different quantities doing different things at different times. And if we can understand these timings and know that we can excite them with 830, then we can do interesting things with wound healing. So in the normal wound healing process, there are 3 stages: inflammation, proliferation, and remodeling. And everyone says, inflammation, enemy. In fact, no. Inflammation, friend. Without inflammation, there is no wound healing. If you take a wound and you slather it with steroids, that cuts down the inflammation, and the wound will take a long time to heal. So inflammation is important. Uncontrolled inflammation is our enemy. So the cells are the mast cells, the macrophages, and the neutrophils, and they all reach their peak within 3 to 4 days and then start to return to their normal levels. And then in the meantime, we go on to proliferation, when the main cells are the fibroblasts and endotheliocytes. These are like little baby blood vessel cells that clump together to form nice new blood vessels or repair damaged blood vessels. And then within about 18 to 21 days, they start to decline in number, and we enter the remodeling phase, the longest phase, and that can last all the way up to about 6 months, 1 year, 2 years or more, depending on the tissue that has been injured and how much has been rebuilt. The cells here are transformational cells because there are now far too many fibroblasts. So some of them change into myofibroblasts. Myofibroblasts are fibroblasts with muscles. And these muscles contain little hooks. And these hooks grab the new collagen fibers, and then the muscles contract, pulling the collagen into nice alignment to give good, tight extracellular matrix. But there are still too many fibroblasts, and another portion are programmed to de-differentiate into fibrocytes. Move what can. And fibrocytes are like unipotent stem cells. They can only redifferentiate into nice young fibroblasts. So what have we done? We have actually enhanced our dermal stem cell pool through wound healing. That's normal wound healing. So what happens if we add 830 nanometer LED LLLT? Well, very interesting things happen to the timing of the wound healing. First of all, the 830 causes very swift degranulation of the mast cells. And the first stage of degranulation is inflammatory. So in fact, rather than stopping the inflammation, the first thing we do is boost the inflammation. And this means that the inflammatory stage cells work even harder. And then the second stage, the first stage lasts for about 12 hours to about 24 hours. And then the second stage kicks in, which is the anti-inflammatory degranulation. And that jumps on the inflammation, quenches it, and it means that we, instead of going 3 to 4 days, we can actually come out of inflammation at 2 to 3 days or even faster. That means we go into proliferation earlier. The fibroblasts are encouraged to work harder, faster, and more efficiently by the 830, and that means we can finish the proliferation stage at 10 to 12 days instead of 21 days or so, and enter remodeling in almost half the time. So that is the benefit of applying 830 nanometers to any kind of wound healing. We have accelerated it and enhanced it. So why has 830 nanometer become the main wavelength for the Healite for many indications? Well, the answer to that is in this paper. It takes you about 10 minutes to read the title because there's so much information in the title alone. There's like 3 studies in the one study. But basically, Sunyoung Lee, Dr. Selim Lee in Korea, had 3 groups of patients, round about 20 patients in each group. The first group received 2 treatments a week for 4 weeks of 830 on its own. The combination group received 830 plus 633, 830 on the Tuesday and 633 on the Thursday for 4 weeks. And the 633 nanometer group received 4 treatments, 633 for 4 weeks. So we also had an unirradiated, sham irradiated control. Follow-up was 12 weeks after the final treatment. No other treatment was allowed, only hypoallergenic soap. Always remember that skin rejuvenation is underpinned by wound healing. So I'm not going to show you any of the pretty pictures of the really nice results in the skin of the wrinkles. What I am going to show you is why these nice results occurred. This is hematoxin and eosin stained specimen from one 49-year-old Korean lady in the 830 nanometer group, and this is before treatment. So there we have the epidermis, a very untidy stratum corneum. Then we have the dermis, which is typically elastotic, full of little spaces. This is a hair in its follicle. And when we look at the condition 2 weeks after the final 830 nanometer treatment, you can see that the H&E staining is much, much more intense. This means basically the collagen is young, good, tight, well organized. Right? So it's a much better organized quality. And then just underneath the dermo-epidermal junction, there is in good young skin a zone called the Grant's zone. And the Grant zone's purpose is to help transmit all the good benefits from the dermis to the epidermis, bearing in mind the epidermis is not vascularized. So the Grant zone helps the basement membrane look after the health and safety of the epidermis. The epidermis itself is thicker and the stratum corneum is better organized. So what we have is same old skin, and what we have here is nice young skin. And again, going back to what Narabal was saying, we have looked after the epidermis, and that's why the total treatment concept looks after both the dermis and the epidermis, so you don't end up with an SOE, same old epidermis, because patients don't like that. 830 nanometer in elastin was exactly the same. We find thicker epidermis, we find better organized elastin fibers, and a nicely organized stratum corneum. Now remember, this is only with light. This is only with 830 nanometers, and no creams, no nothing, no other intervention except hypoallergenic soap. So because the elasticity was interesting, we then thought that we would measure that with a machine, with a cutometer, because machine measurement does not lie. That was the control group, right? No improvement, in fact, a little bit of degrading by the end. Then we looked at the 633 nanometer group, and then we looked at the 830 plus 633 group. Now, when I planned this study, because I arranged this study with Dr. Lee, I believed that this group was going to be the winner. From the very beginning, I thought it was going to be the best, but you see it wasn't. So it's always good to admit when you're wrong, and I was wrong. 830 was the superior wavelength to give elasticity to the skin, unarguable, because this is measured by machine. And the interesting thing is that, yes, we have our 4 treatment weeks, but then you see the elasticity continued to improve during the 12-week follow-up. Why? Any ideas? Remodeling. So we have induced remodeling in normal skin using only light. And then when we looked at what the patients thought, only looking at the excellent scores, we found for the control, as you would expect, not a lot of interest. For the 633, this is the condition at the 4th week of treatment, and then we start to see during the follow-up more and more patients were subjectively scoring their improvement as excellent. This is the group that I thought was going to be best, although it's much better than the 633 alone, and the 830, of course, was king. So 830 better than 830 plus 633, better than 633. We turned back the skin aging clock with LLLT, but without a wound. So let's look at LLLT in actual wound healing. This is a little experiment we did near the beginning of our Healite adventure. 2012 published. The experiment was performed in 2011. We took rats and we created identical burn injuries using a fractional CO2 laser. Then we turned the animals over in a special rig which only exposed the abdomen and prevented any light getting to the wounds themselves. We irradiated at day 0, day 2, and day 5 post-burn, and then we turned the animals over and looked at how they were doing on day 6. This is the control, unirradiated animal, healing very nicely, as the wounds should, because these are not compromised wounds. But when we looked at the indirectly irradiated wounds, you can see they're nearly healed or completely healed. Then when we looked at the figures, these are the control animals, none of them in the fully healed group, some of them still less than 50% healed. But for the indirectly treated animals, yes, all better than 70% healed, and many of them in the fully healed group. That shows you the systemic effect that I was talking about before. But what about direct effect? This young lassie pulled a kitchen knife down on her face, just missing her eye. She went to a trauma centre where they were using 830 nanometers. It was treated by undercut and cut and suture, and this was the result 6 weeks after the final treatment, and it was 4 weeks, 2 treatments a week, 60 joules per square centimetre. Now note this little brown mark, that is not a scar, that's PIH. Because you look at Korean skin the wrong way and you'll get PIH. But look at her eyebrow. Her eyebrow is perfect, the arch of the eyebrow. There is no contraction, there is no scar. This is a young lassie, a young Korean lady who was walking her little doggy in its little doggy carrying basket. And I think the doggy got a little bit fed up and bit her on the nose. Well, it turned infected. She refused antibiotics, so she got some Healite. And this is after 5 days and 4 sessions, and that's after a further 4 sessions given every other day. So that's 9 days from baseline. You can see the inflammation, the infection, and the wounds themselves have all been well dealt with. This gentleman had a filler. Unfortunately, it was badly placed, and it developed this ischemic ulcer. It pinched blood vessels and cut the blood supply to the skin. So you can see it's horrible. It's ulcerated, it's infected, it's inflamed. He was in extreme pain. Once again, 2 weeks after Healite and an escherotomy. Escherotomy is where the clinician pours out the necrotic tissue in the ulcer, right? But you can see that it's calming down, and the area of inflammation and infection is decreasing. Much more so at 3 weeks, and here we are at 6 weeks. Was it 6 weeks past baseline, and 1 week after the final treatment, which was done over 5 weeks. And we can actually expect some more improvement through remodeling. But if you look at that kind of wound, you would expect this to be healing by secondary intention because it's a horrible wound. But it hasn't. It's healed with full re-epithelialization in the final picture. So that's the power of 830 LED LLLT. This poor lady went for a lip tattoo. Unfortunately, she went to an illegal lip tattoo parlor and got this as a result. Horrible infection. She has herpes simplex. The whole lower third of her face is disgustingly swollen. And if you look on the right side of her face, she's got Bell's palsy because of the stress of looking like this. So underneath Healite, this is after 1 week and 5 treatments. This is after 2 weeks, and this is after 3 weeks. So you can see that Healite not only deals with bacterial infection, it can also deal with some forms of herpes or similar viral infection. Different kind of injury. This young man pulled a pan of boiling water down onto his face, just missing his eye. So again, 4 weeks, 2 treatments a week, And this is him 4 weeks after baseline. No PIH and really good looking skin. Here's a much more serious burn. This is an electrician, and he was working on high tension voltage explosion, absolutely took his epidermis off the epidermis, horrible swelling, real pain. So because of this, he was treated over 2 sessions, 4 weeks, twice a week, 4 weeks rest, 4 weeks, twice a week, and here's the final result. Rather nice. He was delighted. Fortunately, his wife was even more delighted because she said he looked younger than he did before he got burned. So the poor man is going to have to go and burn himself every 4 weeks to keep his wife happy. I mean, he needs a blepharoplasty, but Healite can't do everything. Here's a different kind of burn. This is an iatrogenic burn performed by my dear friend and colleague, Professor Mario Reyes from Spain. This is full face laser resurfacing. 3 days after, this is what it looked like. Horrendous. The results, however, were fantastic. And this is still the gold standard for severe photoaging. However, what happens if we use 830 on the other side of her face? That's what happens. And 6 weeks later, you can see the untreated LED side is still extremely red, and there's a bit of scabbing going on up there on the forehead. But when we look at the LED treated side, perfect. So this, after we'd done a few patients, we decided we'd do a study. So we took 60 patients, 30 with LED, 30 without LED, all undergoing the same full face resurfacing with erbium YAG and carbon dioxide. We covered wound healing, as you can see, better than half. We covered pain, erythema, bruising, and edema, all the side effects that could be associated with full face resurfacing, and in every case, the LED treated group was statistically significantly better than the non-LED group. So they concluded that light emitting diode therapy enhances wound healing after laser ablative resurfacing. And you remember back when I showed you how adding 830 to wound healing can cut wound healing time by half. There's the proof, cut by half. You saw some examples of bruising, which were treated with DermaV in one single session. Well, this isn't treated in one session. This is 1 week after full hip replacement surgery. However, after only a few sessions, that's 3 LED sessions, 2 days apart, 830 nanometers, 60 joules per square centimeter, it's gone. Now you know how long that sort of bruising is going to last. You could expect after 2 weeks it's going to be a lovely greenish yellow color, and then it will all turn yellow, and then it will go away. But now it's gone away 7 days after the baseline there. How about acne? How about phototherapy for acne? Well, there are 2 excellent papers in the literature which show that the combination of blue and red, this was blue and red, right? Now we use blue and infrared, really works. The protocol, it was 415 on day 1, which is probably like Tuesday, at 830, 633 on day 3, and this is repeated for 4 weeks. In other words, we leave a day between the 2 treatments. And we repeat this for 4 weeks. In the study, it was followed up for 12 weeks, no topicals, no creams, only hypoallergenic soap. And here at the end of the 4-week treatment, they have achieved, with light only, 50% reduction in papules, nodules, and pustules. And then when the follow-up period, they were very surprised, although I must admit I was not quite so surprised, that this improved to an average of 82% at 12 weeks, and it's still rising. So that is interesting. That's our good old remodeling working again. So there's that lady before and after, light type skin 1, a darker skin type, 4 weeks after the final treatment session. She's got fairly nasty cystic acne in this one, baseline, and at 8 weeks after the final treatment session. Some ice pick scars, something else will need to be done to them. So when we look at the average reduction for the Lee, not the Lee study, the Goldberg study, this is the average reduction for the Lee study. She had even better results, but she had more serious patients. So the more serious the acne, the more active the P. acnes, the more porphyrins are active in the P. acnes, the better the results. And she got up to 90% at the 12-week follow-up. One of her patients, young man, very nice result, lighter skin. Note the lighter skin. When measured by mexameter, the skin in the treated patients was significantly lighter than it was before treatment. And while he probably didn't worry about that, she did. Ladies tend to want to have nice lighter skin. You can see she's got some post-acne redness that would benefit from good old gold toning, followed by 1064. How about difficult to treat situations? Well, here's something my neighbor and I were talking about, which is psoriasis. Psoriasis is a real bugbear. This comes from a published paper published by a Dr. Glynis Ablon in Los Angeles, and she had 9 patients. All of them were recalcitrant psoriasis patients with a minimum of 50% body involvement and minimum of 2 years involvement. In this patient's case, she, as you can see, has just come back from PUVA, psoriasis plus UVA treatment. And all it's done, it's bleached her skin. That's all it's done. It hasn't removed the plaque. This is the result 5 weeks after 8 weeks after 5 treatment sessions with 830. You can see really nice looking skin. And only this one lesion was treated initially, but within 2 to 3 weeks of this picture, several of her other lesions started to improve. So it's the systemic effect. And the thing about psoriasis is it is a systemic autoimmunocompetent disease. So this gives you a clue that LED LLLT is something that can be used maybe in other autoimmunocompetent diseases. Herpes zoster, this young lady had this. It's just about to enter the vesicular stage. However, after 3 LED treatment sessions a day apart, this is the result. Very nice, no sign of any scarring, no sign of any herpes. And here's a different kind of herpes zoster. This is herpes zoster ophthalmicus, much more difficult. And this is in a published paper, published in the Annals of Dermatology. There were 28 subjects with herpes zoster ophthalmicus. 14 had famciclovir as the control group, and the others had famciclovir plus Healite, days 0, 4, 7, and 10. They scored the pain through visual analog score, Healing in the LED group was 13 versus 18 days in the controls, with a highly significant difference of 0.006. Pain in the 830 group was also notably less versus controls. Here's an example. 63-year-old female at baseline, and here she is 1 week after 4 treatment sessions. Light only. They received famciclovir. It also works very nicely on dermatitis. This young lady wanted to treat her acne at home, so she used an alpha hydroxy acid peel kit and was left with irritant contact dermatitis. And this is her after 3 sessions, 3 days apart, completely removed. She's left with some PIH. That will need to be treated with something else. This gentleman, chronic eczema, 62 years old. He had 50 years of eczema from the age of 12 when it suddenly appeared. Fairly large body involvement. It was driving him crazy. This was treated by Bettina Rumeline from Switzerland, and this is the result 8 weeks after the final and 8th treatment session with Healite. I'm in touch with Bettina regularly. We follow up on the patient she's treated, and he's still eczema free. We can help prevent scars with LLLT. We have the highest rate of thyroid cancer in the world in Korea. Probably because we have a very strict screening program, but that makes it an ideal subject for a study, because you treat thyroid cancer with a thyroidectomy, a half-moon incision to remove the offending gland. And because of the weight of the body pulling on the neck, the fact the neck is moving all the time, that is a 99.9% hypertrophic scar. So we had 35 patients in the treated group, 15 in the control. They had Healite 60 joules per square centimeter, that's our standard dose, immediately post-surgery. And this is important. The sooner you can get a surgical wound under Healite, the better. And then daily for 3 days, and then twice a week for 3 weeks. They followed up at 3 months with pigmentation and erythema using mixameter, global assessment and Vancouver scar scale, pigmentation and erythema down, global assessment higher score, and Vancouver scar scale also down, all of them significant in the treatment group compared with the control group. So when we look at them, here's a control group scar at 3 months, and here's a Healite treated scar. There's still a scar. There's always going to be a scar, but it's not pigmented. It's much easier to disguise. Another example, and another example of a treated scar. What about mature or semi-mature hypertrophic scars? Well, here we have 2 typical scars after bilateral total knee replacement surgery, 2 months post-treatment. You can see that they're well on the way to becoming mature scars. Although they are still, you can see they're still fairly flexible and they're still vascularized. However, when we walk on Healite, this is 6 weeks, 2 sessions a week, 4 months post-op, in other words, 2 months from where we saw it before, very nicely receded. No pressure dressing, no intralesional triamcinolone, no injections, nothing, just light. So, Healite 830 LED LLLT is easy to apply. It can be applied by a trained assistant. It's quick and comfortable. 11 minutes if you're using the 830 monohead, and it relaxes patients. In fact, most people go to sleep under the beams. It's highly effective for all sorts of pain and wound healing, and LED phototherapy for acne is something you should really consider. Now, Healite is very effective as a standalone monotherapy. Everyone that you've seen in these clinicals was standalone. But I think that combination is the key. You've heard from Narumon, you heard from Adeline. You know, one thing cannot do everything, and combination is definitely the key. So no matter what you do to your patient, mild or severe, you can creams, chemical peels, powder peels, IPL, fractional laser, etc., etc., etc. You combine it with Healite immediately after the treatment, with the exception of peels and fillers, but I can answer that if you like later, and you'll get synergy. So better and faster healing, shorter downtime, happier patient, better result. That is why, my dear colleagues, no clinic is complete without a Healite.